Welcome to week one of the evaluation and treatment of auditory processing disorders. The course number is 8600. My name is Suzanne Foley, and I welcome you to the course. I do want to say at the beginning that I am aware that many of you may not have had direct experience or a history of working in the field of auditory processing, and that the goal of this course is to reintroduce you to the topic, familiarize yourself with the newest research and updated policies regarding the disorder, and hopefully improve your approach to the disorder in terms of your current clinical experience. The beginning of the course, we're going to be talking just about general changes that have been made to the approach of auditory processing disorders, and we will go through types of testing, evaluation policies, treatment options, reports, and technology involved with auditory processing. So why is this disorder impactful for children and adults? Although most of the course we do focus on children, certainly adults have this disorder, and we will be discussing that in a certain week toward the end of the course. But for children, due to education, this disorder becomes impactful. The reason it's important is that despite all of our great technology, 60 to 70% of all instruction in the classroom is still auditory based. So academic instruction is presented with the assumption that the students are able to hear and understand what's being said in the classroom, and that is not always the case. Those of you that have worked with congenitally hard of hearing children know that there is a correlation between auditory deficits and language and reading difficulties, that having a peripheral hearing loss can lead to a delay in language and reading difficulties. So it makes sense that auditory processing would also be the same. Carol Flexer is one of our colleagues that has done the most significant amount of research in FM systems. And as part of the MARS project in the late 90s, looking at classroom acoustics, one of her research articles stated that on any given day, 1/3 of kindergartners and first graders are not hearing well enough to perceive word sound distinctions. And what we mean by that is the difference between an F as in Frank and an S as in Sam, that auditorily students are not able to hear that difference. And then of course we assign letters from the English language that are not quite fair, don't play fair, and it becomes confusing. So now that's not all because those students have auditory processing. It could be, and part of the research suggested, that it was due to middle ear fluid, whether it's infected or not, wax in the ears, slight hearing loss, congestion, and certainly possibly auditory processing. But with the known incidence of auditory processing, we're not saying that 30% of students have this disorder, but we do know that there's many reasons why auditory information may not be getting to students. The reason that there is so much controversy about auditory processing is when we talk about characteristics of these students, it certainly can be very similar to other etiologies. So if you look at descriptions of student behavior such as Johnny isn't listening, or he's distracted in background noise, he is a poor auditory learner, can't follow multi-step directions. There are a number of etiologies that could cause that: attention deficit disorder, autism spectrum, a language disorder, sensory integration, a learning disability. And so one of the goals of approaching students with these sort of general behavior reports is to really pay attention to what the student is doing when they're not listening or when they're distracted in background noise, and be able to determine where we need to start the differential diagnosis process. Sometimes part of that process is ruling out auditory processing, having an evaluation to say, this is not the cause of the difficulties, and then move on to what might be causing it. In my clinical experience, most of the students I work with, I do not diagnose with an auditory processing disorder. Typically, I'm referring on for further evaluation of attention deficit or a language processing problem, but we have to look at their behaviors. One of the most common complaints I get from parents and teachers when a student is referred to me for an evaluation is that the student doesn't follow multi-step directions. And one of the first things I ask is, when the student is not following the directions, what are they doing? And the classic example I get from families is when a mother will say, well, just this morning I told Johnny to go upstairs, get his backpack and his shoes, and meet me in the car. And so I ask, what does Johnny do? If Johnny goes upstairs and brings something different down, that might be an auditory problem. If he goes upstairs and comes back and asks mom, what did you tell me to get? That might be an auditory problem. If he goes upstairs and watches TV or plays a video game, then we have a distraction problem. And often families or parents will say, oh yes, he went and did something else. Then auditory processing might not be the first place we need to try. But we don't know that until we ask those questions. Many times teachers will report that the student doesn't listen in the classroom. And my next question always is, well, what are they doing when they're not listening? Are they looking at you, appearing to listen, or are they poking their neighbor? Or are they looking under their desk? What is the student doing? And a lot of times we spend hours testing our students and talking to each other when the first step in this process is to watch the student and see what might be going on when they're demonstrating these reported behaviors. What I also say to the parents when they report the difficulty with the following directions is that likely the parent did not use such a succinct instruction. They likely said something like, I can't believe you came downstairs again without your backpack and your shoes. Why do we have to go through this every morning? Go upstairs, get your backpack and shoes, and meet me in the car. We're going to be late again. And typically the parents will chuckle and say, yes, that's what I said. So our perception is that we're giving a short instruction, but really it's what I call a 72-word mom rant. And so, of course, the student is not going to understand that. So we also need to make sure that we're clear in what we're asking the students to do and where they're struggling. So as I said, as we approach the differential diagnosis, sometimes we need to evaluate whatever disorder we think might be a factor and rule out others. We can do that by reviewing test results, academic achievements, grades, speech and language evaluations. We've talked about watching the student. And one of the tips I often give to speech pathologists and teachers and parents is that in our field of working with with students and adults that have decreased hearing, we know that the first human response when someone doesn't seem to follow instruction or understand us is we ask, did you hear me? And what my goal is to retrain people to ask, what did I just say? Because if the student repeats back exactly what was said, then they heard you clearly. It's not an auditory problem. It could be a language problem that they don't understand the meaning of what you asked. So we need to ask, what did I just say? If they said, I was thinking of something else and not listening to you, that might be a sign of an attention deficit problem. If they repeat it back, but it's slightly off, then it could be an auditory problem. But we won't know that until we start to ask, what did I just say, instead of, did you hear me? So since I talk to parents, I use very simple definitions and descriptions. Auditory processing is a very complicated neurologic function, but because I do speak to parents, I want it to be clear. And in the literature, you will see that auditory processing is described as a bottom-up phenomenon, meaning from the time information hits the ears till it gets to the top of the brain, does the student hear catch or cat for cat in a variety of situations. And there are 5 different pathways in the brain that we will learn about that encompass auditory processing. So in those 5 situations, does the student hear cat for cat? And that's what auditory processing evaluates. If the student hears catch for cat, they are certainly going to have difficulty learning what a cat is, because you're explaining an animal and they think you're talking about baseball. So can bottom-up auditory processing lend itself to language and understanding difficulties? Of course, but not because auditory processing testing evaluates the student's ability to understand the meaning. All it does is evaluates a clarity of the signal. So if the student hears cat for cat, but can't spell it or write it or read it or compare it and contrast it to another animal, that is more of a top-down issue in terms of education, reading, speech and language. But the beginning gateway of that whole process is the auditory pathway. So if you have a speech pathologist that's working on higher level, or a teacher's working on academics, more of a top-down skill, and they're not making progress, it could be because the bottom-up signal is not clear and the student is not hearing the information clearly. So we want to make sure we're not missing out on that bottom-up phenomenon. And this is a visual depiction of what I'm talking about. So the lower portion, it says bottom up equals APD. So we're looking at from the ear to the brain. And then the top down language, either reading, communication, learning, is once the information gets to the top of the brain and the output. There are two skills that are in between our two realms, and it's phonological awareness and auditory discrimination. And part of the challenge is when we start looking at skills related to auditory processing, auditory discrimination is listed in our realm of skills, but we do not have a good test for it. We look at a similar skill called auditory closure. Typically, speech pathologists don't evaluate it either, and if you see on the left there, it says pre-linguistic meaning. Phonological awareness and auditory discrim occur prior to language content or the left hemisphere being involved, but it is not included in our evaluation for auditory processing. Phonological awareness is typically referred to as a pre-reading skill, but it really is a very powerful skill in terms of developing language and memory. And phonological awareness is the ability to hear how many sounds are in a word without visual letters. So the ability to know that cat has 3 sounds and they're different. And then if you go from cat to cut, the ability to know that it was the middle sound that changed. And so there's no letters with phonological awareness, no visual, it's all auditory. But if a student can't hear 3 different sounds in cat, and then we assign letters, it's going to be difficult. So often if I see a student whose auditory processing is normal, I will go ahead and do a screening for phonological awareness to make sure we're not missing that piece, because it will definitely affect language development, memory, and reading. So obviously in auditory processing, in the field of it, in audiology, it is different than peripheral hearing loss. And typically I joke very respectfully that we all became audiologists because we didn't want to be speech pathologists. And the reason that this disorder is not as popular with audiologists is it definitely lives in the speech and language world. So audiologists like things to be concrete, black and white. We like the categories of mild, moderate, severe, profound. If you and I talked about those categories, we would agree within 3 dB of what those categories are as far as severity. I could walk into your clinic and do a hearing test with very similar tests as far as pure tone, bone, speech discrim. We might have a little bit difference in the order we use or the stimuli we use in words, but we're going to essentially look at the same type of tests and have the same outcome. With auditory processing, because we're going beyond the ear into the brain, it's not nearly that clear cut. There is not a clear-cut definition of what is mild, moderate, severe, and there is no typical test protocol. We want to evaluate all 5 skills in auditory processing as part of an evaluation, but I may use a completely different set of tests than another audiologist, so it becomes very different. In addition, we can, as audiologists, do a hearing test without talking to any other professional and make a diagnosis on the level of peripheral hearing and share that information. But in order to diagnose, we don't need to talk to anybody else. And again, because we're involved in the brain, it's not that easy. So this, if you specialize in auditory processing, it's important that you learn more about language skills and attention deficit and psychological disorders, academics, a wide variety of topics that we typically don't delve into in traditional audiology or hearing testing. And so over the years, I have made sure that I understand the difference between auditory and language processing and attention deficit and autism, and understand what laws affect students with those disorders. Because often if I am ruling out auditory processing, I need to understand what might be the next step in order to help those families. So when we talk about the prevalence, there is a 2-to-1 male to female ratio. If you look at the literature, when you talk about adults, there is a huge range. And honestly, it says 10 to 20%. And then in patients over the age of 60, you can see statistics that 70% of adults have some auditory processing. And the challenge with all that, those statistics, is that we need to be very critical in our reading of research. Some of those articles that I have vetted may say that 70% of patients over the age of 60 have auditory processing, but there were only 20 subjects in their study. And they also only used one test of auditory processing. So it becomes difficult sometimes to get very accurate numbers of some of these percentages. And there is no data on how many students or adults have auditory processing along with attention deficit, or have racial or ethnic boundaries, because we're talking about such a small number of students and children. So a number of years ago, ASHA and AAA developed some task forces that looked at changing our approach to the evaluation and treatment of auditory processing. And one of their comments was that the prevalence is 3 to 5% of the school-age population. And that is true if you use their criteria, which is that 2 out of the 5 skills that are evaluated have to be -2 standard deviations below the norm. And what that is the 3 to 5% of the population. Those students are typically severely impacted. They're already on education plans, learning disabled, language impaired, dyslexic. We know about those students. And typically, if you talk to audiologists that work in auditory processing, the numbers of 10 to 15% of students have an auditory processing weakness that is likely a significant contributing factor to their difficulty, meaning we want to address it. It's not in that severe range, but it's certainly, the auditory processing deficits are linked to behaviors where the student is struggling. So if you look at causes of auditory processing, 60% of the students that are diagnosed with auditory processing have a developmental delay in their auditory system development, and I'll go through that here in the next slide. If you look at the history of chronic otitis media, the research is 50-50, meaning 50% of the research says, yes, chronic otitis media does lend itself to language and auditory deficits. 50% says it doesn't. One of the challenges, again, of looking at that research is, many of you experience this, that I do a lot of hearing tests on 2-year-olds in our early intervention program, and I will see many students that have a red ear, abnormal hearing test, flat tympanograms. I refer them back to the pediatrician, and the pediatrician sees them the next day and says, let's wait 4 to 6 weeks and see them again. So there may be students walking around with otitis media that we're not aware of, or that the families have tried to get treatment and can't. So it's a little difficult to get those numbers accurate. Jaundice is a new case history or possible cause in the last 10 years, and we're talking about jaundice to the point where they need a blood transfusion. And it's the hypothesis is that the high bilirubin affects the cochlear nucleus up through the brainstem, and so that's something to consider on some of your case histories. Certainly head trauma, a history of any sort of significant illness, lack of oxygen, we want to look at as well. If you do a CT scan or an MRI on all the students that have been diagnosed with an auditory processing disorder, only 1% are going to have what we love to call a cytolesion, which is a horrible term that audiologists like to use, meaning we're going to see a part of the brain that is damaged or is not working. And those students typically have more neurological issues, and auditory processing is not a priority. 60% of the children that are diagnosed, as I said, have a developmental delay. And just as a review, the most direct route from the ear to the brain is diagonal. So all of us are born with our left ear not processing as right as well as our right. And in the literature, it's called a right ear advantage. That is normal development. So when information comes to the right ear, it goes directly diagonally up to the left hemisphere, which is where language is processed. When information comes in the left ear, it goes directly over to the right hemisphere. And again, I'm being very simplistic because I speak to parents, and that is where motor and vision occurs. The information crosses the corpus callosum to reside in the left hemisphere for interpretation. So the left ear has a longer pathway. The left ear is weaker than the right through age 12. By age 12, both ears should be equal. So part of our testing is looking at where is the left ear in that student, for example, for an 8-year-old. Is the left ear where it should be, or is there a developmental delay? The left ear isn't as high as it should be. Research suggests that the difficulty with this disorder is in the corpus callosum, which is the right, where the right and left sides of the brain communicate. And they believe it's due to a lack of myelinization, that the myelin is not fully developed on the corpus callosum. And so I tell parents it's like driving on a gravel driveway or a road. You're going to get there, but it's going to take longer. It's going to be less efficient. Things are going to drop along the way. The goal of treatment for this type of disorder is that if you engage the brain, the right and left hemisphere together, by doing a verbal left hemisphere task with a right motor task, neurons will fire across the corpus callosum and the myelin will be further developed. The way to increase the myelin is to make neurons fire. So I tell families it's like driving over that gravel road several times and it flattens out and becomes more smooth. I also give the analogy that it's like having a weak muscle. If you have a weak muscle, we know based on neuroplasticity that the brain can improve. And so if we work that correct area, we're going to see some improvement in auditory function. So as we have through age 12 for the right and left ears to equal, another fun fact is that as we age, men at age 28 and women at age 42, our corpus callosum function starts to slow down due to age. So many adults, especially women from 35 to 50, who complain they can't hear in background noise, it's likely related to that corpus callosum. So there's only a short window from 12 to that age where our right and left ear are together. The reason this is also difficult to figure out in students is that we also have these other, what I call umbrella issues, such as executive function, memory, attention, working memory, sensory integration, all these other issues that certainly are going to affect bottom up and top down. And so it becomes difficult to figure out the etiology of some of these issues. So what is the impact of auditory processing when you talk about students? Certainly it's going to impact communication. They may have difficulty following auditory information, a history of language delay. They might misinterpret what they hear based on not hearing a tone of voice change, such as when you make a question or you're being sarcastic. And certainly the ability to hear when there's competing noise. Academically, there may be an impact in reading difficulties, the ability to sound out words based on that phonological awareness difficulty. They may not be able to rhyme. They can't keep timing. They're always offbeat a little bit. They can't hear some of the blends in consonants when they go from 1 to 2 sounds, or the ability to hear initial or final sounds. Certainly they can misunderstand classroom instruction and not learn new vocabulary because of that. So as I mentioned earlier, ASHA and AAA, their documents are in your readings for this week. One of the changes is that 20 years ago, if I was going to diagnose a student with auditory processing, I would say the student has an auditory processing disorder, period. I would give some strategies and recommendations. But now, because we know so much more about the brain and we know the brain is plastic, we can improve function. we know that we can improve auditory processing skills. So in order to do that, we need to know where the deficit is. So my analogy about the bicep or muscle is that if I have a weak bicep and I work the tricep, I'm not going to make much progress. We have to know where the deficit is. So one of the changes that was recommended is that we should be very skill deficit in our evaluation so that we can be skill deficit or skill specific in our remediation. So now I'm going to say a student has an auditory processing disorder in the area of auditory closure or temporal processing so that we can be deliberate in what our approach is to treatment. One of the other recommendations is that they changed it from CAPD to APD. They just dropped the C, thinking it was too much like a central nervous system. But some of the new literature coming out has put it back in. So it's the same disorder. On this slide, if you click on this, you will hear a simulation of auditory processing, which I think can be helpful in terms of understanding what the impact can be. There are several controversies related to auditory processing as far as the testing that's used, the diagnosis criteria, and then certainly the remediation. One of the criticisms or controversy is that when we test students, we use words and sentences. And so the question is, are we actually evaluating language or auditory skills? So when we evaluate, we want to be as specific to auditory only stimuli. So we're going to use numbers, which have a low linguistic content. We're going to use tones as much as possible. But the reality is that we do process language. So we need to know how they are processing language. And then certainly anytime we do behavioral testing, even when we do a hearing test, we have to evaluate the accuracy of the responses and make sure that we're watching the student or the patient and looking at their behaviors and considering that in our evaluation and interpretation. Also, because I said there is no gold standard of testing or consistent diagnostic criteria, each audiologist in this field is going to have their own way of doing that. Some don't use mild, moderate, severe. Others have different descriptions they use. So that's one of the controversies is how can we approach this if we don't have very clear-cut criteria. The problem is, again, when you get into the brain, there are so many other things that can affect our testing and the outcome that it's very difficult to be that clear-cut. And then even though it's mentioned of inconsistent normative data, several of our tests have very solid normative data, not only on normal hearing, but there are some tests that have normative data on students with peripheral hearing loss. So we do have a lot of normative data out there on the tests that we use. So as a way to begin the process, because we want to be skill deficit in our approach, we have gone away from sort of categories of testing. So the bold terms on here are the actual auditory processing skill that we're looking at, and then it has a description in the tests. And there are 5 different skills that we want to evaluate in a test. The first is binaural interaction, which is the ability to localize and lateralize, and that's just at the brainstem level, so right beyond the ear. The second is auditory closure, which is the inability to fill in the blanks of what we don't hear clearly. These tests are given for one ear only, and looking at if we filter off the words, can we fill in the blanks? The next 2 go together in the category of dichotic testing, and it's binaural integration. If we give different information to both ears, can we hear both? And then conversely, binaural separation, can we prioritize listening by ignoring what's happening in one ear and listen in the other? The last category is temporal processing, which is timing, the ability for the right hemisphere to hear pitch changes and timing differences that will affect the understanding of speech, inflection in our voice, and the prosodic nature of speech. And so the words below each of these skills are the tests, some of the common tests that are used to evaluate those skills. Again, we're going to go through these. Binaural interaction, again, localization and lateralization. I often caution this is not a common auditory processing skill that we see. The patients that I have seen have this typically have already been diagnosed with a brainstem lesion. I do caution people in education, though, if you see a student doing that, trying to localize and lateralize or look where sound is coming from, we also know that that's consistent with unilateral hearing loss. So we want to make sure we're at least doing a hearing screening. Auditory closure, which again is also listed as discrimination, typically goes with receptive language difficulties. If I only hear "ca" and a little bit of the word and I have to fill in what I might not hear, I have to have a pretty good number of words in my word bank to choose from. So if you hear "ca," you might think that could be catch, cap, C-A-P, C-A-T. It could be cash money. But if I'm a student with receptive vocabulary difficulties, I may only have one or two words, and I'm not going to do very well on that. We will see this also worse in poor acoustic environments with reverberation and background noise. These students are ones that do have difficulty hearing the difference between words and sounds, so phonological awareness, sounding out word difficulties. They have difficulty hearing rapid speakers. So again, it is tested in one ear at a time, and it's right above the brainstem level as far as going up the neurological pathway. I mentioned earlier that 60% of students with auditory processing have the corpus callosum or the inner hemispheric difficulty, and those are the two skills of binaural integration and separation. And again, that's the right ear advantage or the left ear weakness. Okay, the example that I give for this is when you talk on the phone, say you have the phone up to your right ear and you can hear what the person is saying, and someone comes up to the left and starts talking, you can hear and understand both of them. Conversely, you can also just listen to the person on the right and ignore the person on the left. That's separation. And so the result of these difficulties is the students are overwhelmed in background noise. They also cannot do a verbal left hemisphere and a right motor task at the same time. So they can't listen and take notes in class. So you'll see that academic impact. The next one is temporal processing, and these are the students that have a delay in their auditory information getting to the brain. So you'll say something to them and you can literally count backwards and then they'll respond. They also don't hear pitch changes or timing changes that tell them that you're asking a question, that you're being sarcastic, humorous. It's also the difference in something like convict and convict. That stress change they don't hear, so they're certainly not going to understand why you're changing from a noun to a verb. Related issues are the poor rhyming. They misinterpret, so they don't know why everyone was laughing at Bobby on the playground because I thought he was being mean when he was really being funny. They typically are slow processors in general. They're slow readers, slow writers, and so you'll see that timing delay. As far as additional resources in auditory processing, there are lots of great resources. The two documents for this week are the ASHA and AAA task forces. There's also a book, When the Brain Can't Hear by Terry Bellis, which is like a story talking about auditory processing. And then from a parent perspective, Karen Foley's written a great book, Like Sound Through Water, which documents the parent perspective through that disorder.